Okay.
Hey Joni, it's Sam.
Hi.
I don't have a way to like control my video or my audio, but I think I'm just like a participant currently.
Okay, let's see if I can change that.
Okay, thanks.
I'm promoting you.
Oh, that worked.
Did that work?
It works. Thank you.
Did the same for Ryan. Suppose we'll wait just a few more minutes.
Can you guys hear me all right?
I can hear you.
Awesome.
We'll maybe wait just a few more minutes, maybe like 5 minutes tops.
That works.
For some reason, that PowerPoint screen disappeared on me. I have it on my other screen, but yeah, it's not on my
Oh,
computer
I
screen.
did that
Oh, okay. All right. I'm
because
over
I
here.
needed my screen for a minute.
More than cool. I was over here trying to double as IT, figuring it out, but
Nope, it'll go back up there.
more than cool.
Well, I suppose we might as well get started. I don't know how many folks were expecting, but this is being recorded, so people who can catch it in other ways. Welcome to HDC Supporting Families Parenting Series. My name is Joni Dietz, and I'm the Director of Services at the HDC Cloquet office. And thanks for joining us. So tonight we are focusing on the benefits of skills in case management services for children. And we have some providers here who are going to help us learn more about this. Just a few notes, reminder, this is being recorded. You can raise your hand during a session or ask a question in the comments. I'm just going to try and moderate. Anyone can jump in when you like, small group here. And if you are looking for credits for this webinar, you can reach out via the contact us button on the HDC website, or I'll put an email address in the comments as well. Questions, anyone? Let me get the program going. So here is our topic and our overview of what we're looking at today. I'm defining each service, outlining the benefits of these services, and addressing how these services help children's mental health, and discussing how to access these services. And our facilitators today, Samantha Arneson, Lauren Borndal, and Ryan Leonzal. Sorry, did I get those right?
Yep, you're right.
Thanks. Well, who would like to start us off here?
I'll go through this one. This just gives a little bit of a rundown as to what CTSS services are. It suggests that Children's Therapeutic Services and Support is a mental health service designed to provide interventions to clients to return them to normative developmental trajectory. And it gives the Department of Human Services overview as well, suggesting that it addresses the conditions of emotional disturbance that impair and interfere with an individual's ability to function independently. For children with emotional disturbances, rehabilitation means a series of multidisciplinary combination of psychiatrics and psychosocial interventions to both restore a child or adolescent to an age-appropriate developmental trajectory that had been disrupted by a psychiatric illness, or enable the child to self-monitor, compensate for, cope with, counteract, or replace psychosocial skills deficits, skills acquired over the course of psychiatric illness. So ultimately, just in layman's terms, this program ultimately is designed to ultimately kind of piggyback some of what the therapists do during therapy in interactions with the kiddos. Ultimately, my job then, being a CTSS provider, would be to work and coincide with the therapist that sees these kiddos for therapy sessions on a weekly, bi-weekly, monthly basis, and interact and try to hammer out some of the skills that would be helpful for somebody that ultimately went through something that might be causing them a little bit of an issue. The goal with that long term is ultimately to kind of slowly work away at building skills and building different ways of managing some of that psychiatric or developmental issues that have kind of popped up depending on what it is for, whether it was an experience that they lived through or just ultimately a diagnosis that they've had to manage. So ultimately I would be working with the therapist to try to help as much as I possibly can to kind of limit some of those limitations.
Absolutely. And so with that, we just want to focus on, what CTSS looks like in terms of the golden thread. I also should introduce myself. My name is Sam. I'm a therapist at HDC. So like Ryan was saying, he does the skills portion of CTSS. So he's the practitioner that really works with these kids in this specialized service. But the ultimate goal here is that we're looking at the golden thread, and that is what how treatment's all connected. So it starts with, that diagnostic presentation, what the client's coming to us with, what are the symptoms that we're seeing, and the treatment recommendations that all come from that therapeutic standpoint. from that, we get the idea of, what is our treatment plan going to look like? What are the goals we're going to focus on? And then those objectives we're going to work to, or use to work towards that goal per the recommendations from that first step of that diagnostic picture. And then lastly, that builds up to those specific interventions that a client needs identified in that treatment plan. So when we think about CTSS, it is a really valuable service because not only does it help the kid build skills, but it builds off of therapy services. It builds off of that diagnosis that the client is first given when they come in to access this service. So it's a really, like I said, it's that golden thread that connects all of this together and looks at how all this structure can help benefit a client in addressing their mental health concerns.
All right, my name is Lauren and I am also a therapist here at HDC. And so the next slide, this slide that we're talking about addresses a few different diagnoses, discusses some target behaviors, and then gives examples of what goals would look like for the CTSS skills portion. So after a child receives a mental health diagnosis, they'll be assigned a CTSS practitioner per the recommendations of that diagnostic assessment, who will develop specific goals to target specific behaviors that have been causing a functional impairment in their day-to-day lives. So some examples of diagnoses would be depression, ADHD, anxiety, and conduct. Some target behaviors that we have identified are maladaptive coping skills. So we have cutting or self-harm. The ADHD behavior was be blurting or interrupting peers and adults. Anxiety would be avoiding social situations, and an example of a target behavior in conduct would be not following directions. Some goals that we have identified for CTSS specifics would be taking deep breaths or increasing deep breathing, increasing talking to a friend or a safe adult, increasing waiting turns or communication skills. In anxiety for avoiding social situations would be increasing assertive communication. And then a goal for not following directions would be practicing following directions or practicing not walking away. So those are just some examples of diagnosis, target behaviors, and goals. And there are many different goals that we can create based on each diagnosis or individual diagnoses.
All right, this next one is just about the implementation of the CTSS services and the different dynamics in which we provide said services. It suggests CTSS services can be implemented in several ways to best address the impairment in which the client is experiencing and the environment in which the behavior is most noticeable. CTSS skills can be focused within the home, school, or community setting. The ideation most specifically with this is that, as we've all heard, sometimes it takes a village ultimately to impact change, especially with kids. I think kids seem to require maybe a little bit more of a supportive nature from the number of different supports that they have. And kids most specifically, ultimately, whether it's at school or daycare or with their friends or at home, are just provided a number of different environments in which stressors might actually get the best of them. So the ideation with this implementation slide is to just kind of identify in the different dynamics in which we provide services so that we can ultimately, as a support system, speak the same language when we're interacting with the client or trying to build skills or anything of that nature. So individual, working solely with the practitioner to understand treatment goals and start building the foundation for skills for the client. That's ultimately something that I would do with the client on an individual basis, whether it's meeting with them within the schools or in a setting in which they're ultimately comfortable with. And that dynamic is focused specifically on the individual and building trust and building kind of a rapport in which we do it in a fun manner so that the kids rationalize that this is A, important, but B, we can practice some of these things in a setting that isn't extremely regimented. We also do group settings, meeting with a small group of clients to address the treatment goals that require social interactions. Commonly with kids, you see that some of their communication skills are maybe in need of a little bit of work. This gives the kids the opportunity to spend time with very like-minded individuals that are experiencing maybe similar disturbances or completely different ones completely. But ultimately, I've noticed just in my time providing some of these services that commonly kids ultimately feel alone until they realize that they might not be the only one experiencing some of the issues that they might have. So I've noticed that one's ultimately a slam dunk and a hit, because you see these kids really interacting in a manner that they might not feel super comfortable doing at school or at church or wherever else they might be. The family setting, meeting with the family to address treatment goals in the home between caregivers and clients. I've also noticed that to be pretty important, just because, like I said earlier, us as a support staff and as a group, speaking the same language is extremely important. And commonly you'll have kids kind of tell you that everything's cool, and then you'll talk to mom and, well, we might need a little bit of help in this area, and the kid might not initiate having that conversation. So getting everybody together and having a sit down in which you can interact as a group and come up with some group goals as a family, I've noticed to be really impactful and important. And then, as I mentioned earlier, school-based services, meeting with students in schools as allowed to address behavior seen in the classroom setting. Commonly, I've noticed that also provides us a tremendous amount of consistency with people's schedules. It gives us the opportunity to see kids in a setting in which they're most comfortable in, because they go there ultimately all day. And it gives us the opportunity, like I said, to kind of tie the services around all the different areas in which a child might find areas of need or struggle. So those are the different supports that we provide.
So this is just our first questions or comments break. So does anyone have questions or comments to add to the conversation at this time?
I have a comment, if that's okay.
Yeah, of course.
So I wanted to kind of comment on Ryan's slide that he just presented on about the different types of CTSS services, and just kind of mention my focus right now is with some early childhood clients. And so family skills is something that would be very important for that age specifically, because what the client learns and the family learns, it's important to implement back at home as well to kind of continue to see progress. So with providing all those different types of services, individual, family, group, and school-based, it is important to kind of pay attention to what your family needs, what the client needs, and how to best support them in providing maybe even all of the above types of CTSS services at the time. So I just wanted to mention that part too.
Excellent point.
Mm-hmm.
I will take this short silence to indicate that we'll move along.
Okay, so the second service within our child and family team here at HDC is children's mental health case management. And just kind of right off the get-go, we want to identify that children's mental health case management is not the same as CTSS. So CTSS is skill building, looking at where that deficit is, with those coping skills or communication skills, and that practitioner's goal then is to focus on increasing those or maybe decreasing a maladaptive version of that. And really, like I said, looking at skill building. So case management is looking at more of an overview of how the client does in their entire life. So it's a more comprehensive and wraparound service that looks at the function of the client and the family. And then Minnesota statute for case management, specifically children's mental health case management, describes it as somebody who's coordinated to work with the family to find community support services that are going to help that client with their severe emotional disturbance or attain, mental health services, social services, educational services, health services, whatever it may be. So we're looking at, where is the deficit in the whole picture of this client? If they're struggling at school, what is it that the school deficit looks like, and what can that case manager help access, for example? If a client is struggling with getting out and about, finding a recreational activity. What can that case manager do there to then identify what could we link them to? So just want to reiterate, CTSS is skill building, where case manager is that big overview of like, where is that client having a deficit in their overall life.
All right, and so then the next slide is the role of a case manager. And a case manager assesses a child's changing needs, develops a plan with other service providers and the child's family to best address the child's needs, link the child and family to the appropriate community resources, and monitors the effectiveness of planned services. So case managers work very closely with therapists and CTSS providers. It is a service that we provide very, very closely here at HDC, and it monitors therapy services, it monitors CTSS services, and it monitors other community events or community resources that the child is involved in. It could monitor medical appointments, it could monitor how school is going, and it also can link children and families to community resources that they may not be aware of or may have difficulty accessing themselves. So the case manager will assist, and over time will work with the parents to take the lead on accessing community resources. So first, the case manager will help link the family to a service, and then they will monitor the family's engagement in that service and teach the family to access services on their own. So they assess the initial needs of the clients and family, they find appropriate resources to fill those needs, they link the family to those resources, and then they continue and monitor to make sure that it's the right fit, to make sure that it's a positive experience, to make sure that the value and the changes and the value is appropriate and that it makes changes as needed.
Ryan, are you there? Just want to check in.
Yes, I am. I had muted my mic to cough and I had forgot to unmute it. I apologize, guys. The benefits of case management services. I think Sam and Lauren really did a good job kind of conceptualizing exactly what case management provides. This will kind of go into a little bit more depth, but not much. Helping with crisis assistance, addressing independent living skills, helping link parents to resources for parenting support, assess needs for the child and family for educational services, leisure and recreation, home-based treatment, medication monitoring, day treatment, and medical and dental care. So the best way that I can really wrap up ultimately this slide and how we've, without kind of going back on what Sam and Lauren have already kind of suggested, is just CTSS really focuses on skills and skill building and ultimately the managing of any sorts of mental health diagnosis that they might have, whereas the case management connects the dots in some of these other areas that CTSS doesn't specifically work with. And as they had suggested earlier, just kind of connecting the dots in just about every walk of life in terms of holes that might be there, and connecting the dots to make sure the family and the client specifically have access to the resources that could be best and most beneficial to what they're going through. And that can, as you can see, that can be all over the map in terms of the services that a case manager might provide here within HDC.
And like Ryan was saying, we want to really emphasize that these are two very different services. Your child could qualify for both, which is awesome, but we really want to address that CTSS is focusing on skills, developing healthy coping skills, reducing negative. It's therapeutically focused. It's more of a weekly or maybe bi-weekly service. So they're meeting with you in that individual, family, or group skill level. And then it can be addressed, at home, in a school environment, kind of wherever that client needs that skill service. Whereas case management is looking at that broad picture of where in the community is there a deficit. They don't check in as frequently as CTSS, it's monthly. And recognizing it's recommended from a therapist for case management, but it's not always necessarily therapeutically driven. So it's definitely a service that going to HDC to, you know, seek out a case manager is going to be accessing a therapist first to get it, but it's not as closely tied to therapy as a CTSS practitioner would work, or CTSS services are.
All right, so then we have just kind of the basic referral process. Like Sam said, if you would like case management or CTSS services, it would be through a therapist. So calling the intake number, which is listed on our screen, 218-302-8708, and scheduling an initial evaluation. Then what we do is you attend that appointment. The therapist will kind of gain some information about what is kind of happening, what kind of things are we looking for, where are the deficits, and finding what we can best help with. So discussing potential services, including that CTSS and case management. It is something I wanted to point out. You could qualify for both, like Sam said. You could qualify for one or the other as well. And then discussing goals of either of the services would be the next part on our list. Then the therapist will put the referral in for that service. The service provider would then contact the family to schedule an intake session, meet with that family, develop treatment plan goals, and creating a crisis response plan, and then make a plan with the family for how often the services will be utilized through a specific method.
Another moment for questions or comments.
I guess one comment I wanted to make too, because we didn't hint on this, is these services are offered at all locations of HDC. So here at our Duluth office, Cloquet, as well as Lake County. So it's not like CTSS and case management are just at Duluth. They're within all of our Minnesota HDC offices.
Thanks for the addition. So here's everyone's contact information for everyone who contributed today. So I guess that wraps up our slideshow for now, but I'd like to leave things open if there are more questions and comments. Remembering that this is being recorded for potential future use as well. So maybe a question I might have is, if my child needs to go inpatient somewhere, how could your services help?
Ultimately, I think piggybacking some of that, like an inpatient stay most specifically, ultimately, most often when children go to an inpatient setting, they learn a lot of what's called DBT skills, dialectical behavioral therapy. And with that, ultimately, they are taught a number of different skills that are ideally meant to focus on kind of where it's going to meet the kid. Some kids might not specifically care for some of the breathing exercises in terms of skill building, whereas something like guided imagery might really resonate with them. So the idea of DBT, which they would ultimately provide in an inpatient setting like that, would ultimately provide your child specifically with skills. And ultimately, upon discharge, if they were to receive CTSS services, a lot of what I would be doing as a CTSS practitioner would be kind of piggybacking some of those skills. Ultimately, I would talk to the family, I would talk to the client specifically, figure out if there's any skill building that they have utilized in the past. And commonly, it's some of these skills are very widely known by these kiddos because they learn it in therapy. They might practice some of that. So it becomes up to me to piggyback that and teach different spaces in which these skills are appropriate, or different triggers and warning signs. So ultimately, if your child in this specific scenario were to go to an inpatient setting and then receive CTSS services afterwards, the work that I would be doing would ultimately piggyback a lot of what they had learned on an inpatient unit, and it would give them the opportunity to practice some of those skills and incorporate them into their everyday life in a setting that actually provides their daily stressors, as opposed to a setting like an inpatient unit where you're learning for future use potentially. So the ideation of what we are providing is like a very, kind of role-playing dynamic in vivo scenarios in which the stressors are there and obvious, and the ideation of when it's appropriate to utilize which skills is kind of where some of that coaching and modeling comes in. So I think those two pair each other relatively well, outside of the fact that they provide dramatically different settings in terms of when it's appropriate, how it's appropriate, and how they're incorporating it into their daily life. So I hope that answers your question.
Yeah.
And going off that as well, we want to recognize that, CTSS is a really helpful skill, like Ryan said, if a kiddo is leaving residential, because it can help build those skills, or reinforce those skills that they learn there. But we don't want to use CTSS or case management to hold back a kid from that higher level of care that they may need.
Right.
So an inpatient may be something necessary, and we can definitely work through that process of how to get a recommendation in. But we don't want to use these services to kind of band-aid what is actually needed for that client. So CTSS is not something that can say like, well, instead of residential, we're going to do this, because this is a lower level of care, whereas residential or inpatient would be a higher level, more needs, and maybe what that client needs at that time as well. But it can be used once they're discharged, once they're at a different level of service needs.
Thank you. That's helpful. Other comments, questions, talking points?
I guess one other thing I want to mention, and Lauren had brought this up too, is CTSS can be used throughout the lifespan for kiddos. So it can be, for those really early childhood kiddos. We've seen kids as old as, 17, 18 come in for these services. So it's not like you have to have a sweet spot or a sweet number to come in, or like you have to be only 8 years old to get these services. It can be for anybody who really needs it, depending on where they are in the lifespan.
And with that, like Sam said, if you have a kiddo who receives CTSS or case management at age 3, if they qualify for it when they turn 8 or when they get older, they can definitely receive skills and case management again. It's not a one-time thing. It's also not a lifetime thing. So we're not going to be doing skills from 2 to 18 unless it is medically necessary. So I wanted to add those couple points in too.
What happens when my child turns 18?
So I believe, if I remember correctly, the cutoff is actually 21 for CTSS services, but I could be entirely wrong.
No, you're correct.
I think that's
Keep
accurate.
going.
Yeah.
Okay. So they actually can continue with these services until they're 21. And then when they hit that 21 years of age mark, they would then transfer over into the adult side of mental health services. So the adult version of CTSS is called ARMS, and then the case management side of it in the adult world is also case management. So I don't know much on the adult world, but I believe the focus is similar when it comes to ARMS. So working on that skills and maybe more of an adult setting, and case management more in the adult setting as well.
Yes, and I think the nice thing about that 18 to 21 range is that transition can happen within that as well.
This is Allie piping in. One thing I'll add to that is, yes, after 18, it kind of is determined based on what that child is really focusing on, as far as their goals. So if they're really focused on maybe independent living and employment, we might move them into the adult services sooner. Whereas if they're still in school and kind of really managing kind of those types of activities and a lot of communication or relationship kind of areas, we might keep them in the child focused service.
All right, other questions and comments? We can end this earlier. I will give just about another minute, perhaps, to think of anything that anyone would like to add. And I guess that's a wrap. I appreciate everyone's time and contribution. Thank you all for coming.
Thank you.
Thanks, guys. I hope you have a great
Thanks.
day.
Thank you for hosting this, Joni.
Yeah,
No
thank you
problem.
very much.
Thanks for having me.
All right, have a good night, everybody.